and puts it back into your body, so it remains a closed system. That's called a cell saver. And so I don't know if someone here listening is Jehovah's Witness, but I've certainly had patients who are Jehovah's Witnesses who've shown up with a hemoglobin of 3, right? Near death. Like really, they're brought to the clinic in a wheelchair because that's how sick they are. And for a patient like that, the first step is to stop her periods. We've got to stop the bleeding, or else we won't have time to do anything for her. So because she's not going to take a transfusion, like absolutely won't, because she doesn't want to be excommunicated from her congregation. And so in a case like that, you're going to stabilize her, normalize her, put her on medicine to stop the period, and then talk about how are we going to do surgery to remove the fibroids and save the uterus if she's planning future babies.
Wow. Okay,
that was a mouthful.
But it was so great. I see Dr. Katashia was on there that says that she donated blood to herself for myomectomy. If you guys don't know, Dr. Katashia, follow her. She does a lot of things with gut health, and she's really fantastic. I also saw my auntie Grace. I don't know if she's still on here, but she had a question about what causes, prolapse. I don't know if I saw
uterine prolapse. So uterine prolapse is, now some people with fibroids are actually now prone to prolapse because, especially if you're like constipated over the years and you're straining a lot, prolapse really means what we call suspension muscles, right? Those muscles that keep your uterus up inside have gotten so weak that they're not so strong. So the uterus slowly migrates down and sometimes pops out the vagina. So their cervix could be outside, or when they cough, it comes out. The most common cause of prolapse is related to being pregnant and carrying a really big baby and birthing a big baby. And so that's the biggest risk factor for prolapse. But we also know people with chronic gastrointestinal issues like chronic constipation, straining a lot to use the bathroom, etc., can also lead to those muscles weakening or not being as, strong,
holding up,
so to speak.
Right.
Yeah. Because it's a lot of work down there. They're called ligaments, but these ligaments do a lot of heavy lifting, and including holding up a 10-pound baby, sometimes 13-pound baby as it's growing. And so that can really put a lot of stress and tension and stretch them out. But prolapse is common. There are different stages of prolapse. Surgery is available to treat prolapse, but sometimes also we have non-surgical options, like something known as a pessary. Pessary, and we can use a pessary, which is a special thing we put into the vagina, and it helps to push things up. I've even had patients who develop prolapse during pregnancy, and I've had to put a pessary in just to keep the uterus up there while they're pregnant, because we're certainly not going to do surgery for it during pregnancy.
Okay, I hope that answered that question. Let's see what else we have here. People are saying, okay. Thank you for sharing your story. Is there a right time to check for them? Is there an exam to check?
So for fibroids, the diagnostic way, the best way for initial diagnosis or looking for them is ultrasound. So it's an ultrasound. First, they usually ultrasound your belly, but then the ideal ultrasound is the one via the vagina. Most people's fibroids will start becoming symptomatic in their 20s, definitely in their 30s, and for some as late as their 40s. So there's no right time. It really should be assessed for during your annual GYN exam. So here's a public health announcement. Whether or not you're sexually active, whether or not you're trying to have kids, whether or not you need a pap smear, you should be seeing your women's health provider once every year if you identify as female, someone born with a uterus. And every year they should be asking you a few standard questions. How are your periods? What's the frequency of your periods? Are they predictable, regular? Have they changed in nature? Yes, go ahead.
I'm just going to ask a question because that has never happened to me.
Oh my God.
And I have changed doctors because, I got a big mouth. And when I froze my eggs, I asked every question. And the man I did. And even when he was putting me under, I was cussing him out, apparently, because he told my mother when he woke me up, she got on my nerves from right before anesthesia. I was asking all the things. But I really would like for you to even repeat that, because what I have found is I am not abnormal in patients that go for an annual pap smear. How are you? They look at your chart. They may not look at your age or whatever, and they just put the speculum in. They feel around. They do the thing. Do you need any birth control? Do you this? Do you need a prescription for a mammogram? And you're out the door. So one of the things that you've talked about before is booking 2 appointments back to back if you have questions. A lot of us as patients don't always know that. So can you just tell us what we should expect from an annual exam for those of us with ovaries and uterus, and that going to help for that? And if we're not getting it, what we need to make sure we write down, y'all, get a journal.
You got to write it down.
And bring someone with you. Write this down and bring an advocate with you. And if they can't make it, FaceTime them. Because I will FaceTime my friends all the time in a doctor's appointment.
It's helpful, actually. And there's much data.
You need the support, and you deserve it.
Lots of data, especially for women of color. So the first thing to know is the formal name for that annual exam is known as a well woman, well person visit. And so when you call for your appointment, it's a well person checkup. And that should automatically trigger a 30 to 40-minute visit with your doctor's office. It should automatically trigger a very long visit. Now, if they're not doing that, or if someone is still telling you it's going to be 15 minutes, 20 minutes, that's when you get to say, I would like to book a double appointment. And for those who have insurance and are worried about copays, whether your appointment is 20 minutes, 40 minutes, 60 minutes, copay is the same, y'all. So don't worry that you asking for a double appointment is going to lead to a crazy high copay. Secondly, I think it's better to do that than to come in knowing you're going to ask the doctor for 60 minutes, even though they booked you for 40, right? It's better to just say, hey, I need more time. Okay.
Got it.
And it could be because maybe doctor's offices make you nervous. Maybe it's because whenever you show up, you feel like you get sort of like blank in the brain for 20 minutes. So you need a little time. But it also allows your doctor, I think, to know they need to exhale, come in and sit. So I never do a pelvic exam before I talk with the patient fully clothed. I was trained at the University of Rochester, where they really emphasize something known as the biopsychosocial model. And it's very weird to be asking people intimate questions while you're moving around down there. While they're feeling exposed. So it's better for you to be dressed. But yes, these questions are, what are your periods like? Have your periods changed in nature or character? Because that's one of the things, right? A person might be saying their periods are regular, meaning they come at the same interval that they've been coming for the last 10 years. But if you ask that follow-up question, which is, have you noticed any change in your period? Suddenly she's like, yeah, but it only lasts 3 days. It's really light. Or it's like, doctor, I don't know what happened, but it's like a faucet opened up and now my periods are really heavy. So it's important that they ask you that. Unfortunately, to Kelle's point, we also have evidence that says that Black and brown people don't really get asked these questions. Just like they don't really get asked, what are your future family building plans? Even though these are guidelines from the American College of OB-GYN, right? We're actually recommended starting at 30 to ask patients, because we know we're born with just a fixed set of eggs. You're supposed to be asked, what are your future fertility plans? Instead of your doctor assuming that as a 30-something-year-old Black or brown woman, you've already made a bunch of kids. That shouldn't happen, right? Whether you've had 8 kids before or 0 shouldn't change the fact that the guidelines say, I should ask you this. Because I don't know your life. Maybe you want 12. Right. And maybe you don't want children. And if you make it clear to me, Dr. Duke, I have 0 intention of having kids, then I'll make a note in the chart not to ask you this again in the future. But again, I might ask, if you show up and you're telling me you're in a new relationship and things are going great, I may ask you, do you guys have any long-term plans? Any plans of starting a family or growing your family? Because again, it's not an assumption. Fertility issues can affect everyone, including those who've had kids before. And so sadly though, like I said, we do know Black and brown people are asked less frequently. So I want you guys to advocate for yourselves, right? Which is keep a period journal or use the tracking apps, which is why I wanted to make sure people didn't just run and delete their apps, because tracking apps can give you so much good information for your health and a way for you to retrospectively go back and see what's different. what's changed. But if not, keep a journal, right? So you can know when things have changed, when different foods might be affecting your period, when different things might be affecting your intercourse. But you do have to bring it up sometimes. But the first thing is ask for a well person or a well woman exam. Expect it to be minimum 30 minutes. And if they're telling you it's shorter, you can ask for a double appointment. You can ask for 2 appointments back to back.
I love that. You guys, I hope you wrote that down. I hope you bring a journal with you, because sometimes, especially when we are going through changes in our body, Dr. Duke, we don't always remember when our last period was. We don't always remember what the flow was like. Or, like you said, we've normalized our flows being a certain way, so we don't even think it's something to bring up. You guys, it is always something to bring up. You know, I had a dear friend that went in for a sinus infection, and her doctor said to her, anything else going on in you that is different? And she said, well, I'm constipated a lot. And it turned out that he sent her to a doctor that screened her for the colonoscopy, and unfortunately she was diagnosed with cancer. But had he not asked her, is there any other changes to your health, she might not have said that, and she may not have, you know, we may have caught this at a time where her life would have been even less. Yes. So I want to encourage everybody. We're going to ask a couple more questions, and then I have this one that came in earlier, Dr. Duke. There's so many here, and I don't let's see here. What are your thoughts? This is Dr. Katashia. Did it come up? Dr. Katashia, great gut doctor. What are your thoughts on having a partial hysterectomy? My mama Stu had that, and history of endometriosis. How long does it take for the endometriosis to become a problem again?
So I think it first depends on how someone is defining partial hysterectomy. So I would tell you from the context of an OBGYN, when someone says partial hysterectomy, I interpret that to mean what we formally call a subtotal hysterectomy, which means we remove the womb, but we leave the cervix, which is the neck of the womb. I should have brought my model. It's in the other room. But that's
you'll be back. We're doing this again.
And usually we leave the ovaries. And so here's the thing. Endometriosis is actually fed by estrogen. Your ovaries make estrogen. And so there are 2 data points here that would explain what the doc is asking about. So the first thing we know is, even though endometriosis can be all over the body, all over the pelvis, and fed by estrogen, we happen to know that if you just take out the womb, 80% of patients who have pain from their endometriosis will experience relief and improvement in their pain. And so that doesn't mean your endo is gone, and it doesn't mean the thing that's going to feed it is gone, which is your ovaries. So if they didn't take your ovaries and all they took out was the womb, which is what I'm assuming you meant by partial, because that's what we call a partial, is a subtotal hysterectomy, where we just take out the womb, but we leave the cervix. 80% of people will definitely report improvement in their pain. 20% won't feel any improvement, and that's because the endo is still being fed by the estrogen that's there. And then for others, if you're not near the time for menopause, your endo will continue to be fed by the estrogen that your ovaries are making every month, if you're not on other things to help suppress or quiet down the ovaries, right? So what things suppress the ovaries? Well, certainly, birth control pills can help to regulate. We usually just use progesterone-based pills. There are shots we can do. We have tablets now that work like the shot, which is, it regulates what the brain does to talk to the ovaries. So we use what we call agonists and antagonists for a hormone called gonadotropin releasing hormone. People know the medicines as either Lupron or Leuprolide, that's an injection, or they know the tablet as Elagolix, which is Orlissa, and there's another one now, there's another brand with the same active ingredient. So there's that. Or you can be someone who says, I'm going to just try to clean up my life. So you're going to make sure that you're not using things that are what we call endocrine disruptors, making sure you're eating hormone-free, antibiotic-free foods, looking at what cosmetics and chemicals you're using on your body, on your hair, etc., so that you're not absorbing those to also activate things. I usually tell my patients, let's do a combination. Personally, as what I call an excision surgeon for endometriosis, I really go in and we clean up, right? And then we put the ovaries to sleep, because that's what you do. You need to starve endometriosis to have the best lasting results. But we decide on that together, you know, the patient and I. If we're going in to do well, I don't do hysterectomies. I'm a fertility doctor. You're gonna have to pay me billions to take out a uterus.
That's right. That's
yeah,
right.
or if the person's life is truly threatened, then I'll take out a uterus. But otherwise, we're going in to do everything else, clean up, put things to sleep, get them under control. And usually then they're doing really well. I've had patients on suppressive therapy at this point, almost 15 years. I inherited a couple who were already a few years on suppressive therapy, and then I started them and continued. So there are lots of ways, Doc, lots of ways. But yes, a partial hysterectomy, which is known as an SCH, which is a subtotal hysterectomy, can, supracervical hysterectomy is the actual word, SCH, that does help 80% of patients. For the other 20%, we need to go in and finish the job and clean things up.
Okay, I am going. She says, thank you, Dr. Duke. You guys, there are so many questions here, and what we're going to do, we're going to have to just do this again, because you know how we are, but I promised someone that I would ask a question that sent this in the comments, and I also just want to very quickly, I want you to talk about my dynamic uterus that you do on Clubhouse that we love so much and that I've been blessed to be a part of. And I also just want to just briefly talk a little bit about Roe v. Wade in terms of what advice you have for women to continue their healthcare with the world that we're living in now. And you guys, for those that are just joining, this is Dr. Cindy M. Duke. She is head of the Nevada Fertility Institute. She is Yale trained. She is Johns Hopkins trained. She is a virologist and a fertility specialist. And most importantly, she is my friend. And she is the woman that I trust. And even though my frozen eggs are here in Los Angeles, California, when I'm ready to use them, I'm flying them all the way to Nevada.
They'll take your trip to Nevada.
She's the one that's putting them in, y'all. Yes. But I'm going to ask this question here, and then I want to do a little of the Roe v. Wade, and then I want you to tell everybody where they can find you, where they can follow you, where they can become just as obsessed with you as I am. So the question that we got was, I miscarried 13 hours ago. And first and foremost, before I say anything else, I want to say to Lauren, I'm so sorry for your loss. And here on Warrior Wednesdays, we put prayer hands and rainbows up when we know that there has been a miscarriage. Dr. Duke, our very first guest here on Warrior Wednesdays, knows that very well. This is a safe space. This is a space of support and encouragement and love. So you guys, I need you to get to it. Put your prayer hands and your rainbows up in honor of Lauren and her baby. I miscarried 13 hours ago, and this could not have come at a better time, talking about the live with Dr. Duke today. Healing and depressed, but would love to hear, what are the chances of multiple miscarriages for someone like me who is 39 years old and has had 3 with no live births? What are the chances of multiple miscarriages who has had 3 with no live births at the age of 39? I am not giving up, Lauren says, but would like to hear any feedback. Noticed every time I conceived was right after a HSG procedure. I know what that is. I know you know very well.
The hysterosalpingogram.
Exactly. I hope, Lauren, that if you are here now, that you see the rainbows and prayer hands. Thank you, Warrior Tribe, that are putting up there. If you see this after it's posted, you know from my voice that they are there for you. She continues to say, can this be recommended on a regular if this could be my issue and not infertility? Thank you for listening. She says she will be tuning in today at 3.
Yeah. So full disclosure, I know Lauren. So I just want to make it clear that my answers that I'm about to give are not personalized to Lauren, because Lauren is my patient. So
she says thank you right there. Okay, yes, good.
Lauren and I know each other very well. So I am actually going to answer this more generally. Even though she publicly shared her story, I don't want to publicly answer her personal details. But what I would say is there are a couple of factors at play that anyone who's listening should be aware of. So the truth is, as we age, our eggs are aging, and so their reproductive competence decreases, such that the older an egg, the higher the likelihood that the embryo forming could have chromosomal issues going on, what we call medically aneuploidy, which is chromosome number being abnormal compared to the usual 46 count that we see, meaning 23 coming from eggs, 23 chromosomes coming from sperm. And so with aneuploidy comes an increased risk of pregnancy loss or miscarriage. So that's one thing. And so as we age, we have higher rates of aneuploidy, such that by the time someone gets to 44, if they were to conceive, because there's only a 1 to 2% chance they'll get pregnant, there's a 98% chance that pregnancy will miscarry due to chromosomal issue. And so that's really the number one reason that usually happens. And so at 39, for example, it's about 75% almost of the cause is going to be due to chromosomal issues in the embryo, which is not something we're able to see unless we do IVF. It's the only way to figure that out before pregnancy and actually put in an embryo that is not affected. So that's one. But there are other things that can go on. So even if it's 75% of patients who are 39 will have a loss due to chromosomal issues, the other 25% may be other things, thyroid issues. It could be due to fibroids or polyps sitting in the cavity of the womb. It could be due to a clotting disorder or other autoimmune issues. So there are a number of things at play. Now, Lauren highlights that, she seems to have this association between conception and recent time of HSG, hysterosalpingogram, which is the dye test that flushes the tubes. And the truth is, yes, in the 2 to 3 months and up to 2 to 3 months following an HSG, the chance of sperm and egg meeting does improve by about 20 to 30%. Now, I'm not saying you have a 20 or 30% chance of pregnancy, but I'm saying whatever your number is, it increases by 20 or 30%. So for example, if your chance of pregnancy in this month is 15%, in the up to 3 months after an HSG, so month 1, month 2, month 3, your chance is now 18% because it's gone up by 20%, right? Okay. And so that's what I mean. It goes up by 20 to 30%, but that's really what we mean. So I want people to understand that. So yes, there is that idea that now that you've flushed out the tubes, if there's any mucus or gunk that was sort of slowing up the highway's clear.
The highway's clear, right.
It's clear. So sperm and egg can meet, and now once they've met, that embryo can come down and implant. But that does not mean, and the other thing is, let's define infertility. So for strictest sense, infertility is inability to conceive, but the spectrum of infertility actually has another part to its umbrella, which is recurrent pregnancy loss. And so I know there are folks out there who, Kelle, I don't know if you know this, but 50% of people who are referred to a fertility specialist never even make appointment or keep their appointment for the first time. Do you know that?
No.
50%, 50. And part of it is for some of them, they're like, well, I don't need to see a fertility specialist. I have kids, so I'm not infertile. Others say, well, I don't have a fertility problem. I keep getting pregnant. I just need someone to help me figure out why I'm not staying pregnant. But the truth is, we treat all of that. And sometimes the treatment is the same. Again, for example, someone who's over 35, recurrent pregnancy loss, part of your treatment might need to be IVF, not because your sperm and egg can't meet, but because we need to do those genetic tests to see what the chromosomal status is of the embryo, so that we can then select a healthy chromosomally euploid embryo to transplant.
That's super important. And Lauren, thank you for putting that, and thank you, Dr. Duke, for protecting her privacy. And at the same time, Lauren, I am glad that you were here and you got to see those rainbows and those hands up. And a little bit off of what you said, just to quickly transition to the Roe v. Wade, and then I want you to tell everybody where they can find you, Dr. Duke, because you talked about IVF and genetic testing, and that's one of the things that is that
potentially on the line.
Potentially on the line here with the reversal of Roe v. Wade. If anybody knows me, you already know my stance on all of this, and our human rights to choose medically what is best for our own life. But one of the things that I think people do not understand is that with the reversal of Roe v. Wade, which was enacted in 1973, that legalized abortion, that what the trickle down will be is whether or not they take away the right for us to create embryos, to store embryos, to implant embryos for those that need reproductive assistance, you guys. So this is not just one issue. This is an issue that, like Dr. Duke says, that really goes under a very huge umbrella for those of us that need assistance in our family building. So very quickly, Dr. Duke, if you could just speak to that a little bit, and also to any advice that you have for people that are still going to need medical care and understanding what's at stake here.
Well, I also want to let people know, so I'm going to give it in two parts. There's actually a direct impact of the overturn of Roe v. Wade right now on certain fertility patients. So, for example, unfortunately, fertility treatments do also come with a slightly increased risk of ectopic pregnancy. In states where, with Roe v. being overturned, it went back to state law. In states where even ectopic pregnancy, you have to wait till the woman's life or the pregnant person's life is under direct threat, meaning the heart's doing what I just had happen to me when I described needing the transfusion, like you're unstable hemodynamically. Those patients are directly at risk. Someone who's pregnant with what we call a high order multiple, maybe, again, I don't recommend this, and this is why we recommend only one embryo at a time, is whenever you put in 2 or more embryos, the risk of triplets, quadruplets, septuplets, big numbers is a possibility. Now, for someone any person, even the healthiest, youngest person pregnant with 3 or more babies, that is now a high risk pregnancy. If you're someone in particular with other underlying issues like high blood pressure, diabetes, etc., this is now a super, super, super high risk pregnancy. And it may make more sense to do what's called selective reduction, which is to decrease the number of babies you're pregnant with.
Y'all listening?
Discovered to help keep that person safe so they can make it to viability, so that their babies are actually born and so that they can
stay alive
and take care of their kids. So in those states where the overturn of Roe v. Wade meant the federal protections were gone and now it triggered state law being enacted, they were immediately directly impacted if they were slated for a selective reduction, but now cannot have that. Now they're literally in a true high risk, and it's touch or go what's going to happen unless they go to another state with resources that they can use. So there are direct, immediate impacts right now, already happening. Right now. I want people to know that. So what we're talking about is not just speculation. Roe v. Wade being overturned has already impacted certain fertility patients in this country. Now, what it also led to, though, is there are a number of states that have been mulling certain bills and amendments known more colloquially as personhood amendments, which there are variations of them, but essentially personhood means the idea that the moment sperm and egg meet, a person is formed. This is not after it's implanted. It means just as soon as sperm and egg have met, the concept in the people pushing personhood amendment is that a person just formed. That is actually not
true.
It's not true. Sperm and egg coming together. You've now formed a zygote, an embryo,
y'all.
Something that can implant potentially into the womb, but there's no conception. Without implantation, there's no conception. And I recognize that overall, that's not taught in school. Sex ed really never covered that, so people don't understand that overall. But the truth is, that's the thing. However, that's what we do a lot of in fertility clinics, right? We're putting sperm and egg together in the laboratory. If a state were to pass a law that now says the moment we put sperm and egg together, we've created a person, now all the person laws go into place, right? And so suddenly, even though this is your embryo, if you decided not to use it, you may actually have to get a court order against you. Someone can take a court order out against you, potentially, that limits you from doing that. If you wanted to move your embryos from one state to another, although you can usually just decide to move and take your children who are born, with the personhood bills, you may again need to get permission to move your embryos, etc. And so it's important to, what I want to tell people before I leave today is, first and foremost, it's important to go figure out what's going on in your state.
Yeah.
It's important to know that in the upcoming elections, when you vote, you're not just voting for the people who are going to Congress or the Senate. You're voting for the people who are the law enforcement in your area, right? If if abortion and even the treatment of miscarriage and ectopic pregnancy, which is not an abortion,
is not an abortion,
and it's not a pregnancy. First of all, we shouldn't be calling it pregnancy because it's not something that could ever potentially yield a baby. It's not possible.
You guys, what she's talking about ectopic is when sperm meets egg inside of the fallopian tube.
Inside the tube or on the ovary or the cervix, just not in the cavity.
Not here. In the womb. It can become septic and it can kill the person that is.
It can just hemorrhage. And yes, I had a patient last year where I took out 2 liters of blood from her belly from a ruptured ectopic. 2 liters of blood. A full Coca-Cola, that's 2 liters.
That's 2 liters.
Right? And that was just sitting in her belly.
Hemorrhaging.
Hemorrhaging. I want people to understand that was never going to yield a baby, but it was definitely going to take her life if I hadn't addressed it then and there. Prior to us having surgery and ways to address this, ectopic pregnancy was a leading cause of death of reproductive age women. And in places where they don't have these resources available, it remains a leading cause of death in reproductive age women. It's important for people to know that. But here's the thing, right? I want people to know you have to pay attention to all your elections. So, school board election, are they going to make sex ed something now illegal so you don't even learn about contraceptives? Is your local sheriff, the person running for sheriff, is this someone who potentially could be a Joe Arpaio like guy and decides to, go after people so that they can get a case going to the Supreme Court? Who's going to be your local attorney general, your state's attorney general? You need to know who these people are, and of course, who's running for your state senate and your state lawmaker legislative offices, because these are people who can vote to either codify Roe into law or people who can further restrict your options. And so you need to be aware. You're not just voting for president or the U.S. Senate or the Congress. You're voting for the people in your county. You're voting for the people in your school board. You're voting for the people who are going to be your sheriff. If you're worried that, oh my God, they could use my period tracking information to subpoena information about me. It's not your state senator who's going to subpoena that information. It's going to be your attorney general, your prosecutor, and or your sheriff's department, right? Now, personally, Kelle, and you know how I feel about this, I think anyone considering doing stuff like that, like policing someone's period tracking app, I think they should take those resources and figure out what's going on with all those untested rape kits we have in this country.
Okay.
That's what we need to do.
I am going to leave it there, because if I get into any of it, you already know my temperament. But first and foremost, I want to thank you, not just for your time, but for your absolute wisdom, wisdom, and for the education, for your transparency, talking about fibroids and what you went through, and for your passion and your relatability to telling us not only what we needed to know medically, but what is at stake. You guys, when you vote, these are life and death decisions, literally. And so that is why Dr. Duke and I do the work that we do. She does the work that she does with her own patients, but she takes the time to come here to speak to you, to educate you, and to share her truth with you so that you are empowered to make the right decisions for yourself. This is a purpose and a calling, and we are just so lucky and blessed and honored that she takes the time to be here on Warrior Wednesdays. Dr. Duke, there are still so many questions, so I'm going to have to tell you and ask you and beg you to come back when you have time with your fabulous look and your red lips and all of that. And listen, Ani, and you're my friend, and I can't wait to be able to really hug you and all of those things. But tell everybody where they can find you. If you guys are not following Dr. Duke, follow her right now. Send this to a friend. Tell them to follow her right now. But she also is on Clubhouse doing something called My Dynamic Uterus. So tell them all the things.
Yeah. So My Dynamic Uterus was founded at this point in December 2020, and it really was based on what we talked about today, which is helping people recognize that the period is a vital sign. just like your blood pressure, your heart rate, and to normalize conversations around periods, which ends up meaning conversations about reproductive health, because we really talk about pre-puberty, puberty, all the years in your 20s, your 30s, your 40s, your 50s, and after menopause. That's what a conversation about periods ends up being about. It's all phases of that reproductive span. And so join us on Clubhouse. It is the largest pregnancy fertility focus club on Clubhouse, and it's every Saturday. We were on hiatus. I'm not going to lie, like Kelle, I kind of semi-retired myself. I had a lot of other things going on. One, I had to take care of my own health after what happened in September. And then we had a number of changes and transitions happen with the business, and we're growing and doing so much more. So I had to really hone in on that, focus on that, get the team to where we needed to be. And then I went to Rwanda. So I traveled to Rwanda a month ago, which we'll have to talk about in a separate live, Kelle.
Yes.
Because I learned so much from that, and so much about food and just the amazing options available for us that we've actually ended up being limited to in terms of what our ancestral diets have historically afforded us. But bottom line is, My Dynamic Uterus, every Saturday morning at 7 a.m. Pacific time, we talk about periods. It's an opportunity for you to come on stage, ask a question, we answer. Clubhouse, yes, it can be toxic, but not our rooms. We're respectful.
Right. She said that your room is amazing, though, and it is amazing, and it's across the world, you guys. She's answering questions from women in India, around the world. It's beautiful to hear.
It's amazing. And then, of course, I'm here on Instagram. I really got active with my reels of late, and so like I now use my Wednesdays to prepare reels that I then share with people during the week. So check them out. They're very informative. And of course, you can find me on Twitter, LinkedIn, Pinterest, Facebook.
All the things. I tell you, this has been a friendship that has been so rewarding to me. I adore you, and I love you, and I thank you so much for
the feeling is mutual.
I just adore you, and if there's anything that the warrior community can ever do to aid in any of the things that you're doing, you know that I specifically and us at large are here for you. We thank you. I will be texting you, and we'll be doing this again. It'll take me a while to get this up, but you already know, girl, we did that thing.
We did it. I'm really glad we did, because we've both been really busy, but I felt like we needed to come in and just let people know that the real from the not so real, and the fact that our world is changing, but we have to still stay in control, right? You've got to stay in control of your health, and don't give up at all.
Thank you for not giving up on me and calling me and saying, girl, we get on live. This is Dr. Duke's Live, you guys. We just happen to be on Warriors. So I am sending you nothing but blessings and love, and I will speak to you soon. Thank you so much for being here. I love you.
Bye, everybody.
Bye, everybody. I will talk to you soon. I'm going to post it now. Mwah. Thanks for coming through.
Bye.